We all have 2 copies of all of our genes on chromosome 17. I always remember it's chromosome 17. There's 17 letters in neurofibromatosis in case you ever forget which chromosome NF1 is on. I am Josh Hersheson. I'm the adult clinical lead at the Guy's Neurofibromatosis Service. Thank you for inviting me here today. I'm going to talk, I try and make this as general a talk as possible. The real challenge with talking about NF1 is how variable it is and how different everyone's experiences are. Try and focus on some of the common questions that we get asked, some of the common information that we will try and get across in clinics. Everyone who has NF1 is unique, not just as an individual, but in terms of the particular set of problems that they may have, and the journey that they've had to come and see me, or in their lives. We'll try and make this as useful as I can, but there will be I'm sure there will be some things that I will not mention. And if you have any questions at the end or anything else that you wanted me to ask, we can try and talk about that. A bit about me. I qualified as a consultant neurologist in 2019, and my first job was in the Guy's NF service. So it's 2 complex NF1 services in England, together with my colleagues in Manchester. So we see patients with NF1 with additional sort of complicated or complex features. We also see patients with NF1 who we would consider non-complex as regards not having other particular issues, which we'll discuss. So we do see all patients with NF1, but we can't see everyone because we're sort of only relatively small compared to the total number of people with NF1, but we try and see as many as we can. I'm sure most of you in here already know what NF1 is. I'll just give you a little genetic reminder in case you need it. So NF1 is a genetic condition. We consider it to be a predisposition to developing nerve sheath tumors. There are other nerve sheath tumor predisposition conditions, NF2, schwannomatosis. NF1 is quite unique and has a particular set of problems, and it's also the most common out of all of those. It's a relatively common neurogenetic or genetic condition as regards the number of people in the UK, and it's about 1 in 3,000 across the globally actually, people who have NF1. The most important thing I try and say whenever I see someone with NF1 for the first time is just to get across how variable a condition it is. There are a large number of issues that can affect people with NF1, and each of those can affect people in a highly variable way, from very mild to very severe and everything in between. Most people will normally show signs and potentially be able to be diagnosed with NF1 very early in life, if people spot or recognize the particular skin manifestations, but they may not always develop at birth. Well, typically, in the vast majority of people, have signs in the skin, cafe au lait, freckling, that will allow for a diagnosis to be made. One of the commonest features is obviously skin neurofibroma, but again, it's very variable in the extent and the location, but one of the most common manifestations, and lots of other manifestations. Just a little bit about the genetics. This is more relevant in terms of sort of the family planning discussions that we have, but also in just understanding how NF1 comes to be. We all have 2 copies of all of our genes on chromosome 17. I always remember it's chromosome 17. There's 17 letters in neurofibromatosis in case you ever forget which chromosome NF1 is on. You can count it, there definitely are. We all have 2 copies of our genes. Everyone has 2 copies of an NF1 gene, except in sperm and egg cells, where there's 1 copy of all of the genes. NF1 codes for a gene called neurofibromin, which is a gene that is important in how cells grow. There's lots of genes that do that. NF1 is one of those. And we need both copies working for it to do its job. And if one copy doesn't work, you essentially get NF1. Many people with NF1 will have inherited it from a relative, one parent, but many people, the spelling mistake, the mutation will have occurred for the first time in them as an individual, either from the sperm cell that they came from or the egg cell, and we call that a de novo or from new mutation or spontaneous mutation. The relevance for that is it's only the individual affected and future children at risk, but their relatives have no risk because it wasn't an inherited condition. It's heritable, it can be passed on, but not inherited. Another way that people can have NF1 is this slightly harder to explain mosaic form, where there's no spelling mistake in the sperm or the egg or the initial fertilized egg, but at some time after cells divide, an NF1 mutation in one of the cells, and all of the cells that come from that one affected cell will also carry that mutation, and that can explain why people can have manifestations in just one part of the body. We sort of call that a segmental form of NF1. So, and that can be just as severe or mild as any other form of NF1. But importantly, when we try and look for the genetic cause in blood, we often don't find it, and there are slightly different considerations in terms of family planning. But those are the main ways that you can have NF1. The main ways that we will diagnose it are on a particular set of clinical features. The commonest, as we know, would be the skin manifestations, freckles in the armpit, groin, or under the breasts, multiple birthmark or cafe au lait. And then there are a number of other features which we can sort of see here. And these are pictures to show some of the features. They're not necessarily representative of the spectrum. And I just want to get across that. Obviously, we've got the cafe au lait, freckling. These are leash nodules. Leash nodules they're not the same as freckles. They're just a clinical feature. They don't need to be monitored. I'll just make that point. It's just useful as for diagnosis. Obviously, if you have a family history, there we can see skin neurofibromas obviously come in different shapes and sizes and locations. That's a rather large plexiform neurofibroma in someone's leg. Pseudoarthrosis is an abnormality of how the bones have formed and will typically affect children, can be mild or can be severe, requiring surgery. And then a particular benign tumor of the optic pathway called an optic pathway glioma. So those are the kind of the core features that needs to be, at least some of those need to be present in order to make a diagnosis. But just to put that in context, as I said, they all occur on or exist in a wide spectrum. And this table here is just useful at giving some of the percentages of how often these things occur. So as we say, the skin features are by far and away the most common. Also common but not across the border, the neurodevelopmental issues like ADHD, autistic spectrum disorder, dyspraxia, learning difficulties, which tend to be mild to moderate, very occasionally can be severe, and obviously that's in addition to any other neurodevelopmental issues like an ASD. Plexiform neurofibroma, I mean, just to say they don't occur spontaneously in adulthood, so if they're there or they exist, they will have been there usually since childhood, even if you didn't know that they were there. Some people worry if they haven't got them, are they going to develop them? It's possible that we don't know that there is an underlying plexiform and that will grow, but typically they will manifest or show themselves for the first time in childhood, or at the point that we do some scanning internally for things that we don't know about. Blood pressure is there's a much higher rate of blood pressure, higher blood pressure, just normal high blood pressure, so what we call essential hypertension in NF1, but there are various other causes of high blood pressure. And that just shows the list and how common various things are. That's not an exhaustive list. There are lots of other things on there that we will see in our range of patients, but they tend to be much less common. And so that's kind of relevant when you're, particularly parents who've just who've just found out they have a child with NF1, and they're trying to understand what may happen. And it's very hard for anyone to predict for a child who's just been born with NF1 what problems they're going to have, save for they're very likely to have some changes in the skin, but that doesn't give us any indication as to how many or how severely they're going to be affected. It gets a lot easier for me looking after adults, because by the time people reach adulthood, you have a much better idea, not a complete idea, but a much better idea of how people have been affected, because a lot of these things will manifest in childhood. And if you haven't got some of these by late adolescence or early adulthood, you're not going to get them. An example would be an optic pathway glioma. These only appear in childhood, and if you haven't got them, you're an adult, you're not going to develop them. It's one of the things that only affect children. Other things can come up later in life, so it's not to say that by the time you get to adulthood, you know exactly what things you're going to get. And there are lots of important things that we try and get across in terms of self-monitoring and being aware of things that can occur later in life. But just thinking about some of the common things, what is a neurofibroma? And here we're talking about sort of skin neurofibroma or plexiform neurofibroma. This is obviously just showing skin neurofibroma in the cartoon on the right. This is just a map of the nervous system showing the brain, the spinal cord, and all of the peripheral nerves. And obviously the skin, which is sort of just the wrapper of the body, but is covered in very small nerves in the skin, sort of cutaneous nerves. Neurofibroma arise from nerves, but specifically they arise from the lining of the nerves that we call a nerve sheath. And nerve sheaths are generally provided by a particular cell called a Schwann cell. And the tumors that we see, whether they're from the peripheral nerves internally or the skin nerves, are all arising from the nerve sheath. But there's lots of different types of these neurofibroma. In the skin, they will appear in many shapes and sizes. Some just will look like a bit of texture on the skin if you shine a light. Some will look like a soft sort of lump. Some will be obviously more prominent. It's not always possible for us to say definitively that a lump is a neurofibroma, but often we can be quite confident, particularly when people have other neurofibroma. Internally, we often see larger tumors than we see in the skin. And again, this is not in everybody, but tumors can be very large, and they can form from multiple nerves, which we call a plexiform neurofibroma, and they can range from small plexiforms, and you can have plexiforms in the skin and the tissue under the skin. They can be in the muscle, they can be in any of the peripheral nerves. Neurofibromatosis is a condition that can cause anything, but the more, when you see a lot of people with NF1, you will see the spectrum, but in terms of the individual, that it's not to say that just because anything can happen that necessarily will. And that is one of the challenges with having NF1 and sort of managing the uncertainty of what may happen. But you can get neurofibroma anywhere in the skin or in the nerves. In the brain, we don't get neurofibroma as such because there's no Schwann cells in the brain, but we can talk about that. But in terms of the skin, they often will occur not necessarily in young children, but as you get older, the likelihood increases of developing neurofibroma. People ask me whether or not there's any particular time in their life when they're not going to develop or they're going to stop developing. Unfortunately, I think the answer to that is I can't say that with any confidence. I believe they can at any point throughout life. Mostly, I would say the patients that I see, the vast majority of their neurofibroma don't cause them particular issues in terms of symptoms. The impact on visible difference or the psychological impact is separate, and that doesn't necessarily relate to the I try and not use the word objective severity because everything's very subjective, but the psychological impact can vary hugely according to people's experiences. But mostly the skin neurofibromas don't cause many problems, but they absolutely can. And individually they can be itchy, painful, they can bleed. There can be generalized itch, which can be problematic. Individually, they can normally be removed relatively straightforwardly, normally by plastic surgery. Sometimes GPs may do them or dermatologists, but we would typically refer to plastic surgery. We often get asked about whether or not a certain technique is good for NF1. In practice, I'm a neurologist and I'm not a surgeon, and my role as I see it is to recognize that somebody or listen to somebody's symptoms and recognize that they will benefit from having something done. But I would generally defer to the plastic surgeon as to what the most appropriate surgical technique is. And there are a range from excision to electrodesiccation. Occasionally laser treatment is used, but there's not one treatment for NF1. I think the point that I would generally make is that on the NHS in practice, having neurofibroma removed from the skin is generally on the basis that they are symptomatic and causing problems, and that's usually for a limited number. That's not to say that large numbers can't be removed, sometimes under general anaesthetic, if a large number are causing problems and there's a significant burden of neurofibroma. But it's generally for the plastic surgeon to decide on what the most appropriate kind of surgical management would be. I often get asked, is there anything I can do to prevent the appearance of neurofibroma? Unfortunately, to my mind, there isn't. It's a very random, unpredictable process. Random and unpredictable doesn't necessarily mean inevitable. It's just, if you ask me what's going to happen, I can't tell you. It's a lot easier to say what has happened over the last year than it is for me to say what is going to happen over the next year. And again, we completely recognize that this leads to uncertainty, and that can be challenging. And it's important to recognize, for us as clinicians, to recognize that. Often get asked whether or not we should or shouldn't recommend particular things like hormonal treatments, contraceptive, HRT. In general, the advice we give is that you should take those on the merits of the reason that you're taking them for, whether it's contraception or treating menopause. The impact on neurofibroma, I always keep an open mind as to what we don't know, but there's not strong enough evidence to suggest that you shouldn't do these things. And you are weighing the clear benefits of one thing over the sort of the uncertain or speculative risks of something else. So I would always I would always go to what are the clear benefits, because the risks are actually quite unknown. In pregnancy, a lot of women will say that their neurofibroma is increased, and that absolutely is something that we hear very frequently. There's very few studies to confirm this. There's only one study that sort of suggests it isn't the case. One study suggesting it isn't the case is not evidence that it's not true. There probably is some bias towards reporting it, and actually, because it's so variable, it would be interesting to know across all pregnancies what the actual rate of significant increase in neurofibroma is. We actually don't know. That's not to say it's not true, though. And then, importantly, issues related to visible difference. And there are various ways that we can support patients with that in terms of co-opting other charities like Changing Faces. We have our own psychologists, but it is a big challenge, or it can be a big challenge. So we do like to talk about what the possibilities are, what are the expectations about management. If we completely understand when individuals or patients would rather not have any neurofibroma. Unfortunately, the reality is of having NF1 with neurofibroma is we can't do anything to stop the appearance of them. So but it is important that we manage what the expectations are of what surgical intervention can do and what may happen in the future. And sometimes that is around managing the uncertainty of the condition. Itch is very common, and we like to give general advice for itch. Neurofibroma often have lots of mast cells in them. Mast cells have histamine. So histamine is the chemical that gets released when you get an insect bite or causes itch in the skin. And so antihistamines can be helpful for itch related to neurofibromatosis. Either an antihistamine tablet, like a non-drowsy hay fever tablet, or sometimes a topical antihistamine, like an insect bite cream, if it's just a local area of itch. Sometimes people will need to have some of their neurofibromas removed if they're so itchy that they're just scratching them all the time and then causing lots of bleeding. And again, we've talked about how removing symptomatic neurofibroma is absolutely indicated, ideally via plastic surgery. People ask whether or not they grow, removing one will cause the growth of others, and that's not the case. It's certainly the case if you remove one, but there's some tissue left that it can grow, but it's also possible to remove it in its entirety. Depends on how deep it was to start with and how good the plastic surgeon was. But mostly they don't grow back. But there may be others nearby that were going to grow in any case. And in terms of the psychological support, a certain type of psychological therapy, acceptance and commitment therapy, can be quite helpful at managing the uncertainty of this condition. And there are excellent charities like Changing Faces who have their own sort of nurse support about supporting visible difference. They do have a counselling service. There's lots of information, and there's a very useful online sort of resource that some patients to about managing kind of concerns around visible difference. Just in terms of plexiforms, obviously these can be, because the word plexiform doesn't imply that it's very large, it just speaks to the nature of the tumor, but they can be very large or can be very problematic. The issues can relate to the size or the bulk. They can be painful, they can cause problems with clothing. Internally, they're more problematic when they're in tight spaces, so inside the spinal canal or in the pelvis, particularly if they can squash local structures. But the tumors themselves are often very soft, and often people have had them for a very long time before they're even noticed. This is for the internal ones. That's not to say they can't cause problems, but just having them isn't inherently worrying. Obviously, most people would rather they didn't have it at all, but it's very common for us to find when we do a baseline scan internal plexiforms that we either need to monitor or we just need to tell people that they're there just in case they develop symptoms later on. As I said, they don't tend to come on. They don't develop later in life, but they may grow throughout life if they're there already. Often, most of the growth can be in childhood, or through puberty. Mostly, we don't need to do anything about plexiform neurofibromas. I'd say mostly, the majority, that does that there aren't, that it is important to be aware of the issues that can arise from plexiforms, and certainly some absolutely do need some surgical intervention, particularly when they're symptomatic. We're very focused on symptoms being the key. Just because something's there, if it's not causing any problems, if there's not a likely future risk of causing problems, then we would tend to leave something there, because often removing something will have risk in and of itself, and that risk may not be justified if there aren't any clear immediate benefits, i.e. you're not trying to address any particular symptoms. But we have to be aware of what symptoms do warrant further assessment, and this is absolutely crucial. And this underlies the information that we will try and communicate really from our sort of first transition appointment and then throughout life. And this is one of the not the only, but one of the key things that everyone who sees everyone who has NF1 and everyone who sees patients with NF1 needs to get across, and that's what to do when symptoms change, and what are those symptoms that we would be concerned about. Plexiforms and neurofibromas are often very soft and squidgy. Sometimes they're a bit firmer, but certainly plexiforms are often quite soft. But if a tumor becomes hard, it starts growing rapidly. By rapidly, I mean where something wasn't growing before and we're seeing growth over weeks and short months. That would indicate something has changed in that tumor, and and particularly if there's pain or new neurological symptom like weakness or numbness associated with that tumor. And it very much depends on where it is as to what additional symptoms you might expect. The only symptoms may be a change in texture or pain, but all of those things in a known tumor would warrant some further urgent reassessment. And this is to do with the risk of a cancerous change within the tumor. So the tumor becoming malignant, which we call a malignant peripheral nerve sheath tumor, which is a type of sarcoma. And they tend to be quite aggressive. They tend to grow quite rapidly, and they virtually always will be associated with significant symptoms. So it's the change in symptoms that's key. It's always easier to spot in people or to self-recognize when there's a relatively low burden of symptoms. But obviously we're talking about pain here, and some patients do suffer with difficult and chronic pain. And so how do you know if the change in pain relates to a problem like this? But it's the change, and it's a sustained change over time, and it's progressive symptoms. If it's an internal tumor, you may not be able to feel anything, but there may be. But the key indicator may be the pain. If it was pain that was, as I said, getting worse, particularly pain keeping people up at nighttime, where they didn't have that previously. And what would we do? We'd want to see these people urgently, and that's obviously we're talking about our own service. But if this was we would expect a GP to refer to an urgent service. There are sarcoma services set up around the country, which are set up to diagnose these conditions rapidly. Often the imaging, there'll be some urgent imaging like an MRI or a CT PET, which is a special type of CT with a radioactive dye that helps us target a biopsy. We may do likely to undertake a biopsy, and this is normally going to be overseen by a sarcoma team. To support the diagnostic pathway. We would expect to be referred patients who had had a sarcoma, so that we can also support their care. But the most important thing is really for patients, as much as is possible, or their carers, or their primary or their GPs, or the people that look after them, to be able to recognize when symptoms warrant urgent concern. Because there's no amount of clinical review. You can see someone every 6 months or every year or every 2 years, but it's not that's going to spot this. It's the change in symptoms, and it's the fact that symptoms are recognized as needing some urgent assessment. Let's talk about brain glioma. They are relatively common, but very variable. We kind of divide them into optic pathway glioma and non-optic pathway glioma. The optic pathway glioma, as I said, only really affect children, and a minority of those will ever need any treatment. So we don't generally scan children in childhood unless there are some symptoms like a headache or something else that would warrant an investigation. And occasionally these things are picked up incidentally from a child who's being investigated for migraines, for example, noted to have an optic pathway glioma. But it's the reason that children will have regular eye tests, regular eye assessments throughout childhood, is to spot any changes that would warrant sort of further assessment. But the majority of these won't cause problems. So just knowing, this is one of the reasons we wouldn't scan every child who's got NF1. It will generate a lot of anxiety, a lot more scans. Often it would need to be done under general anesthetic. But if there is some symptom in child, I don't look after children. There are very nice guidelines on Nerve Tumours UK about symptoms in children that would warrant referral. But that's one of the reasons that we don't scan children. But if we see an optic pathway glioma in adulthood, we generally would want to make sure their vision was normal, but we wouldn't continue to monitor that. However, the other type of glioma, which is a non-optic pathway glioma, which can occur anywhere, and these can be anything from a very small area of we say signal change, because often we're looking at MRIs and you can't know what something is. You just describe it on the basis of how bright or dark it is. So we say sort of that there can be a bright sort of area that we think is consistent with a probable, so there's a lot of uncertainty here, with a probable or presumed low grade. Low grade means not presumed to be not growing rapidly. Low grade glioma. Glioma is equivalent to a neurofibroma, if you like. In the brain, the myelin is provided by glial cells. So in the brain, you get the glioma, which arise from glial cells. And in the skin, you get neurofibroma. If we see one in adulthood, we tend to monitor them annually for 5 years, depending on whether, and if there's no growth, we would stop scanning. That's a pretty typical way of monitoring these. If there's growth, sometimes people will need to have a biopsy. Occasionally, they'll need to be removed. Anyone, whether they're known to have any symptoms or not, should make sure they go seek assessment if they have some unusual symptoms, new progressive headache, visual symptoms, if the optician said there's any sign of swelling behind the eye, or if they ever develop any new neurological symptoms. This is true for anyone, whether you've got NF1 or not, and common sense would probably say that should anyone develop these symptoms, they're going to want to go and get assessed rapidly. Obviously, if you're known to have a brain tumor that's being monitored, you're still going to do the same thing, but obviously people will need to interpret those symptoms in the context of the tumor that's already known about. So I'm just going to talk about selumetinib. I don't know if my colleagues from Alexion are still here. So selumetinib, or Koselugo, which is Alexion's drug. It's currently the only drug that's available for children with NF1. It is only available for children to start treatment under the age of 18. There are no equivalent drugs currently available for adults above the age of 18. So it's a drug that was developed to treat neurofibroma, specifically plexiform neurofibroma, specifically plexiform neurofibroma that are causing symptoms where there are no surgical options. So this is a symptomatic, inoperable plexiform neurofibroma. And that, in my experience, is a relative minority of the people who have neurofibroma. That's not to say that some plexiforms can't be symptomatic, but there are other ways of addressing symptoms in terms of pain management or surgery where that's possible. But there are certainly tumors which are very difficult to remove, or they're very, very large, causing a lot of symptoms, and there aren't other treatments. So this drug is the only drug currently available to address that. But it is essentially a form of chemotherapy. I say a form of chemotherapy, and it's given by oncologists. It's a tablet treatment. Does have a lot of monitoring requirements, and it's akin to chemotherapy, and it is given as chemotherapy or similar drugs are given as chemotherapy for other drugs, but it's not given for cancer. It's not a treatment for cancers related to the plexiform tumor. So it's being given for benign tumors. We wouldn't give it in the context of someone who had an NF1 sarcoma or MPNST. It is available via the two complex services in Guy's and Manchester, but it's only available to be given for people who've been assessed by those services. So if people have complex plexiforms, in order to access this, they would need to be assessed by one of those two services, and then they would be referred to a local oncologist, a pediatric oncologist, to deliver that treatment. So I'm just talking about transition to adult services, really important, and we normally will do this from age 16 to 18. You can do transition beyond that, but that's when we like to do it. And it's up until this point, children with NF1, saying they've been dragged kicking and screaming to their hospital appointments, but from age 16, we just try and encourage more independence, more autonomy. It's not because of neurodevelopmental issues in NF1, some learning difficulties, not always appropriate to have certain conversations at age 16, and not every 16-year-old is necessarily ready to start hearing about future family planning, but we will take an individual view on this, but assume that individuals and young adults want to take an active interest in their health, and we try and encourage that. Like to encourage them to read their clinic letters and just understand what it is that we're saying, what the outcomes are. Try and encourage them to start sort of checking and chasing their appointments. This is a process. Don't expect them to cede control, or parents to cede control to their children immediately, but it is a process that we encourage, and at some point would expect young adults to take to be taking an increased responsibility where appropriate, because there are clearly people who still need long-term advocacy. It can be challenging for parents. We recognise where there's been where there has been understandable anxiety, and because we move naturally when we move to the adult clinic to a period of less monitoring, and we move to less monitoring because less monitoring is needed because adults need less monitoring than children. There are fewer issues that progress. It's not to say they don't need any monitoring, but a lot of it can be done as self-monitoring. So this just speaks to something that Karen was mentioning about sort of challenges with GPs, but it's not just about GPs. It's about knowing the NHS is not one organisation. If you go to Tesco's, you wouldn't expect them to have your Sainsbury's. What's the club card? You go to Sainsbury's, you wouldn't expect them to have your club card vouchers in Tesco's. But a lot of people do think that if you go to different hospitals, that everywhere's going to share notes, and that may be true of certain hospitals. It's not true across the board, particularly when you're coming to our clinic and going to Manchester, or when your care has been in lots of other hospitals. We try our best to get all of the information, get all of the scans across. But if you've had a scan recently, we wouldn't necessarily know about that. So it's very useful to keep a folder of your records. I'm sure many of you do, just so that when you go to hospitals, you've got everything to hand, and particularly if things have happened since you were last seen. Often we'll make recommendations in letters, but the worst thing that you can ever do is assume that once a letter goes to the GP that they're going to read that, they're going to action it without you having to sort of chase them. It may be frustrating to feel that you have to do that, but the reality is that if you don't, you're probably the only person that knows that hasn't been done. And it's absolutely fine to be frustrated, but I would say be frustrated and channel that frustration into action, which is sometimes as simple as just reminding, pointing saying to your GP, I've received a copy of this letter. There's a few things that we need to discuss, or I'm just checking if you've seen that and action that point. And if you don't hear back, you can just keep sending that message, and then you can escalate it to the practice manager. But if you don't do it, it may not happen. It should happen, but GPs are busy. Everyone's busy, and it can be very easy to miss something that's at the bottom of a letter. We are all human, and you have an absolutely reasonable expectation for things happening, and things should happen. And if someone says they're going to do something and doesn't do it, you can absolutely hold them to account. But if you don't chase it, it probably won't happen, or may not happen. And so it's very helpful to do that, and it keeps you empowered, particularly if you know how to chase, or if you've been referred to a particular hospital, you can chase with your GP, or if it was me, I would call the hospital directly, because otherwise you're just asking the GP. If you know they've done something, or just asking to chase something, they would just have to call the hospital. You can probably, if you can get that number or that contact number, you can find it yourself. But that is super important, and I'm sure many of you do that, and I'm sure many of you done it and still not got anywhere. But try not to give up. Knowing important contact numbers is really important. We try and put all of those on our clinic letters. Email, we prefer, not just talking about our service. The thing about email is there's a trail, there's a chain. You can keep sending it. You can put urgent in the subject title. You can say, I've clearly sent you 4 emails, you haven't responded. A lot of patients where they'll call up, they won't be able to leave an answer phone message. And as an individual, you think you've kind of chased, but we don't know that you've called. But if there's an email, then it's much more helpful. Not everyone will use email, and we have to accommodate that. But email's usually best for chasing anything, if you can get an email, and phone. So just briefly about the sort of surveillance recommendations. I'm not going to talk about surveillance in children, but this is just adults. When we see adults, we like to do a baseline MRI of their brain and their whole spine. Some places there will be whole body MRI, but the most important thing is to know about the brain and the whole spine. If there's any particular symptoms, we may do some additional scans. We may be monitoring things that we've identified, like low-grade tumors in the brain, for 5 years after we found them. And as I said, we don't need to monitor asymptomatic, so that's optic pathway gliomas that haven't caused problems in childhood, generally don't need monitoring. Because we've never seen them progress in adulthood, and not just us as an individual. This is that they do not progress in adulthood. What we have seen very rarely is people who've had very severe optic pathway gliomas, who've been treated in adulthood, later in life can have a worsening in their vision, and that can cause some consternation for their oncologists who think that maybe the tumour is progressing. In our experience, that hasn't been the case. Blood pressure every year is super important. If you haven't got a machine, just do one, buy one if you can. You can go to your GP, but it's so easy to do yourself. I always do encourage you to try and do it yourself. This is lifelong advice. Opticians, we say every 2 years. If you want to go every year, that's fine. If you have got something, if you have a brain tumor or you've had an optic pathway glioma, we tend to say every year. And it's not the glasses, the spectacles prescription we're interested in. It's the visual field. It's the visual acuity test at the beginning. It's the eye function, not how good the eye is focused. How strong your glasses are really has very little to do with NF1. Very important to discuss and educate about breast monitoring. So for women from late adolescence, early adulthood, checking your breasts every month, as part of a regular health routine. A very good charity, Copper Feel, which will give you a free text reminder on that. And the current recommendations are for annual surveillance mammograms between the ages of 40 to 50. The information that we've previously discussed on what symptoms to be aware of, self-monitoring of plexiforms. So we talked about the breast cancer risk. There is a moderately increased risk. These guidelines are related to moderate risk, not NF1 as such. It's just that NF1 confers moderate risk of breast cancer. So the additional risk is, the highest additional risk is felt to be between the ages of 40 to 50. There's slightly higher risk between the younger than that, but the current guidelines are for mammograms from the age of 40. After that, it's every 3 years as part of the national screening program. But if anyone finds any lumps, then it's just straight to the GP via a diagnostic 2-week wait pathway. Talked a bit about neurodiversity. It's very common, and it's so common that we would expect it to have been assessed in childhood. Often the learning disability may be mild, can be moderate or severe, but obviously it can be in the context of autistic spectrum disorders. The most important thing to my mind is that these things are recognised. There's a reasonable question as to whether or not what you're describing is an NF1 specific neurodevelopmental issue that looks like an autistic spectrum disorder, an ADHD and learning difficulties, or whether or not it's best just to assess them as individual conditions. In practice, they are diagnosed as individual conditions, but they're reasonably seen in the context of all the other things that can affect someone with NF1. That may be relevant to how people perceive those issues, but the most important thing is recognizing, particularly in children, what those problems are and how they can be best supported in terms of reasonable adjustments. It can be difficult to get referrals as an adult. Can be quite difficult to get referral from the local authority. There are often waiting times in excess of 3 years, but there are services set up via right to choose pathways where people can get more rapid assessments in the private sector for ADHD or autism funded by the NHS. And there's quite a lot of information from other charities like ADHD UK and the National Autistic Society. ADHD UK actually has a very useful section which covers ASD, autistic spectrum disorders, and ADHD right to choose pathways. Family planning is very important. Try and talk about that from transition and for adults when appropriate. There's a 50% chance of passing on the condition. What we can't know is how severely a child will be affected. Individuals with NF1 and a known mutation would be eligible for family planning options, and that can include the most interventional prenatal genetic testing, which is a type of IVF, which is testing of embryos created through IVF, screening those out, and then implanting unaffected embryos. So you'd be eligible for that if you have no unaffected children. So you can have a child with NF1 and still be eligible, but if you have an unaffected child, you'd no longer be eligible on the NHS. You can still get it privately, but not on the NHS. And treatment would have to start before the age of 40 in terms of the female partner. Just going to talk briefly about this. So most women with NF1 can have a normal pregnancy. We like to do make sure people have had an MRI of their whole spine, make sure there's not going to be any issues in terms of pelvic plexiforms or issues for an anaesthetist in terms of an epidural. It causes a lot of anxiety for anaesthetists, but we try and anticipate this by doing some baseline imaging to make sure there's not going to be any problems. But most women will be able to have a normal pregnancy and delivery, but there can be issues, and some women will be considered high risk if they have certain features of NF1. But not everyone with NF1 would be considered high risk. It depends on their particular set of problems that they have. High blood pressure, very important to recognize in pregnancy for various reasons, but particularly in NF1, may prompt screening for a type of adrenal tumor called a pheochromocytoma. I'm just going to scroll through some of these common questions. I think we're probably running over time, but I've mentioned that having lumps removed doesn't trigger the growth of other neurofibroma. Tattoos, they are absolutely safe, but can be painful if you're going to tattoo over a neurofibroma. We talked about contraception. I don't think there's not that much evidence that it causes growth in neurofibroma. Often get asked about supplements. You can take whatever supplement you want, but there's no evidence that it's going to, in our opinion, that it makes any difference in terms of neurofibroma. You have to consider the cost of supplements. You have to consider potential interactions of other medications you're taking. I try and keep a neutral view. I can't recommend these, but provided they're not harmful, I will remain neutral. But in terms of any known supplements, there's nothing that will that we're aware of that will reduce the risk of any of the features of NF1. The most important thing really is very boring lifestyle advice. That's sort of healthy eating, blood pressure control, vascular risk management. In terms of things that are going to keep people healthiest for longest in NF1, it's probably those. We talked about this. GPs not referring for treatment on the NHS. It's quite common, but where people have symptoms, that's what I think people need to stress. There are a list of, many authorities have a list of benign skin conditions which they say they won't fund. Unfortunately, in those lists, neurofibromas are commonly on there. And that list includes skin tags and other very benign skin lesions. I think quite reasonably, NHS services say they can't remove everything. I think it's unreasonable, however, to include neurofibroma in that list just because it's a lifelong condition. And the fact is that most people are asking for neurofibroma to be removed, it's because they're symptomatic. And so often we hear, no, we can't remove it because it's for a cosmetic reason. There is a difference in having something removed because you don't like the look of it and having something removed because it is causing you symptoms. So very much have to focus on the symptoms. And in fact, all of those lists do normally say, unless they are causing recurrent infection or bleeding, and most places should be able to remove them. It's there can be barriers, but I think it's important to know what you should say and pushing back on these things. And if you have an NF advocate, Nerve Tumours UK or another service, then I'm always happy to write strongly worded letters. Or to be honest, most of the time we just refer patient ourselves. So often get asked if NF1 will get you benefits. Not the NF1 per se. I mean, the PIP application, if anyone has PIP, it's generally not about the underlying diagnosis, but it is about the particular problems that you have. If you have an ASD or a learning difficulty or a visual impairment, or it's the problems, it's not the underlying diagnosis. So NF1 as such won't, but the particular complications of NF1 may well do. So we often get asked about current research, and in the UK, in terms of NF1, there's no current clinical trials. Nerve Tumours has a good list of current research. We are currently supporting a commercial trial looking at gene therapy. It's quite interesting, but I mean, our role is really just trying to provide some nerve tissue, some neurofibroma tissue for the purposes of the cell model. So we'll keep you updated as to any developments, but it's quite an interesting project looking at gene therapy and NF1. But that's really just at a cell model stage. Probably gone over, but thanks very much.